That's all in my head and in my dreams. But in about 10 days' time, I am going on holiday, so I'm just sort of trying to get ahead of the game, get in the spirit, as they say.
Very good. Hi, Shepard, Chris, Peter. Good afternoon.
Good afternoon. Hello, everyone.
Hey, good afternoon. I'll give it 1 more minute and then we'll start. Hi, Carl.
Hi, Hein.
Hi, James.
Hi.
Right, I'm going to make a start. I think there will be a few more who will join us, but good afternoon, everyone at the March Primary Care Commissioning Committee. Doris is sending her apologies, so I will be chairing the meeting today. The meeting is being recorded and will be broadcasted afterwards on YouTube. And as you may have seen from last month's video, it is now available with BSL interpretation. It's worth looking, if only for that. We have a pretty full agenda, so I'll try and keep everything going on time. There were no chair's actions, which takes me to the apologies. So Doris cannot make it. James Foster has sent his apologies. Sue Merton, Mark Burgess, Jude Bowler. That's as far as we're aware of. Declarations of interest, you will have seen the register. Just an encouragement to all of you to make sure it's up to date and that it also reflects direct family members if applicable. That takes me to a review of the minutes of the last meeting. I will take it in its entirety. So on the minutes, are there any comments as to accuracy of the minutes? I take it as a no. Then many thanks, Sarah, for preparing a good set of quality minutes. Action log. There were 2. One was already declared completed in the pre-read, and I think the second one we can cover as part of the risk register, but I think it's reflected as intended in an action log. So I think we can mark both of those as complete. Forward planner, you want to say anything on that, Sadie?
Hopefully the explanations are clear on that. Hein, you have asked us to extend the length of the forward planner to include April, May and June meetings, which have now been established. So we'll do that in time for the next meeting.
Yes, many thanks. That takes us to item 6, the risk register. Some of them have been updated also pursuant to the discussion we had last time. So welcome any comments people may have on the risk register as they went through it. Got a few myself, but let me first test with anybody on the call. Sadie, please go ahead.
If I may just point out a couple of things on PC10, which is the gabapentins risk. We had a little bit of an arrow issue. So we talked last month about reviewing the scoring for that, which has been reviewed and has changed. However, the downward arrow mistakenly wasn't added. So just wanted to point that out for you. The other item which I would just mention is that on PC13, which is the resilience risk, we're proposing a change of date to that, to reflect the current situation that's continuing.
Yeah, I think it's entirely fair, Sadie. Just wanted to note PC6, the learning disability health check, and I know Shepard will shortly talk to that topic, but yeah, it's worth highlighting, and I think all the actions were either completed or green, but I think the tracker is rightfully on red. So maybe we can, once we've had the discussion at agenda item 7, just confirm that that is indeed the case. The other one I wanted to highlight, PC15, which is on page 35. The primary care hub's loss of capital funding. I think, John, you highlighted it last time as probably the risk profile or exposure has gone up. Is there any update as far as you're aware of, or is it appropriate to bring this back in near term to the committee?
It's a good point, Heinz. So yes, it will be good to have an update, I think, to the next meeting. My understanding is that there have been more positive discussions recently through NHS England regional team about the timescales for the process, which was what was causing the concern before. But I don't have a recent update to be able to share, I'm afraid. So, you know, I would suggest actually a briefing for the next meeting would be helpful.
Sadie, can you pick that up? Thank you. Good. If there are no further comments, we'll also maybe on. Sorry, go ahead, John.
Just one other comment, Heinz. Sorry, it's a bit slow with the hand. So PC11, which was about the interface issues, the interface risks. It's shown as a red risk still, but wasn't quite sure from the risk summary in here. It talks about gaps in controls. It's talking about meetings, but then the update seemed to be that we have had meetings. We've made some progress with the policy. So we're just wanting to understand, I suppose, what is the nature of that risk as we see it now? Is it being mitigated, or is there still a risk?
Sadie.
Yeah, so the interface group continues to meet quite regularly. The next meeting is next week. The interface policy has been the first thing that we've worked on, but we haven't yet been able to get that approved across all providers, and it's only just being implemented, so the impact isn't necessarily being felt from that yet. The other main issue that we're talking about at the moment is the referral routine and the access policy from private consultants, and we have tried on a number of occasions to have a task and finish group around that, but we haven't been able to get everybody together for various reasons. So we're doing that through the main meeting, and there are some fundamental kind of differences of opinion around that, which we're working through. And again, there's no impact from that work yet because it's ongoing. So I think whilst everybody's very positive about the group and the direction of travel, we are still in a position where fundamentally kind of we're still at the beginning of the work. So I think that's why the risk rating hasn't yet changed because of that.
Yeah, I recall Lois would come ideally every 3 months to give an update to the committee. Yeah. So probably next month it will be 3 months ago. So it might be worth planning that in, and we get a bit more color around progress made and still points outstanding. So thanks, Sadie. Good. If there's no further comments on the risk register, we move on to item 7, learning disability health checks, and that's over to you, Shepard.
Thank you, Hein. I will take the paper as read, but I just want to draw the attention to page 3 and just to talk a little bit about the numbers. I've assumed that the committee will be interested to get some sense where we think we are going to land end of this quarter, and also our thinking going forward. So if I look at page 3, and I'll start with the
Yeah, so that's page 39 of the pack, I think, correct?
Thank you.
Yeah.
Thank you for that. If I start with Great Yarmouth and Waveney, you can see that in terms of the uptake at the end of January, they're at 49%. And if you cross-look at the regional position, you can see actually in terms of performance, they are actually one of the top performing localities. And we are projecting that they will be hitting the target of 75% or more. So, and that is the projection they are also giving to us. They've requested additional resources through Protect Now, and that resource is being worked through. So I'm positive that the history suggests that they will hit the target, and the work that we are doing with them, they will be able to hit that target. Again, looking at North Norfolk, they didn't have a great start, but you would notice from previous reporting that there have been significant improvements in their numbers. And we're expecting that locality to be able to hit the target again. Looking at Norwich, you will recall or remember that this was the locality that was not doing at all very well in the past. It was the least performing locality, and that is our targets were reduced by that locality, and they are now leading on this piece of work, and we are projecting that they'll be able to hit the target of 75% or more. The additional resources are still in place. Reviews continue to be carried out at an accelerated level in this quarter. Okay, so the remaining two, so starting with the South Norfolk, I think that is the locality that is probably most challenged at the moment, and additional resources are being worked out. And we've done a submission to senior management, and it's going through that process. So we hope that we'll get the approvals to be able to put additional resources into that space. It's going to be tight. It's going to be a close call. Then West Norfolk, whilst the numbers are showing that it's the least performing, we've intensified our efforts in that locality. Additional resources have been put there, and the numbers will significantly change at the end of the quarter. We've got 3 learning disabilities nurses working with individual practice, and lots of feedback that we'll be able to provide to the system going forward. So in terms of our overall lending position, I think it's going to be pretty much a close call on the overall position, with some more work to do to bring other parts of the system in the next year, so that we can start at a strong position in Q1 and sustain that up to the end of the following year. I will stop there and answer any questions if I can.
Very good. Thanks for the update. I'm sure there are questions. Rosemary.
Thanks, Hein. Yes, I have got a question about the South Norfolk. I gather that there is some support come forward that may be being put in place. Well, it first came to light, I think, yesterday, but we've only got 3 weeks to go. And I just wonder why the support for that area came about so late, really.
I would probably, we've just recently received some additional funding that could help to improve that position. So it's partly to do with funding, and also to do with the locality plans that did not materialize at the time of our discussions.
Okay, so the funding, I gather, is to have a third-party provider. Is that correct? Provide this service?
So there are two parts to that. The first part is about the administration function, which is through Protect Now that we are working through.
Yeah.
So they'll be able to organize that. Then the second part is to do with the third part provider, clinical provider, and we're still going through the approval process for that.
Right, so with the third-party provider, I mean, probably realistically, by the time everything's set up, none of this will be happening till next week, will it, really, if you're looking for space and accommodation in general practice? If those checks spill over into the first quarter of next year, i.e. into April, any checks that are done then, will they count towards this financial year, or will they just start the beginning of the next financial year?
It'll be the next financial year, but we are hoping that we may be able to get 2 weeks in this year if that is approved. I think learning from what has happened in West Norfolk locality, actually practices are able to mobilize much quicker. So if we are able to get at least 2 weeks once we get our approval and working on average of 5 to 6 patients a day, I think we would have made a huge difference in this year. So the small improvement possibly in this year.
Okay, that sounds, coming from a practice, that sounds very challenging, I have to say. But good luck. Thank you.
Thank you.
Thanks, Rosemary. Tracy.
Yeah, thank you. I mean, I'm really pleased about the Norwich achievement being my locality, but I do know there's been a huge concerted effort to do that, certainly working closely with the PCN as well. So, and thinking about, knowing that we have different geographies across the patch, and obviously it might be challenging. Norwich has got one big PCN and a supporting infrastructure. Some of the other localities are smaller areas. So I'm just wondering, are we capturing kind of the lessons learned and kind of what we've put in place in the areas that have been successful to take that forwards to next year? And also, that we're kind of spreading it out a little bit during the year, that we're not just rushing, because I'm aware that if we go to birthdays, for instance, that makes it easier. But certainly if we've done a huge bulk towards the end of the year, I'm just thinking about spreading that out and not leaving it all till the end of the year again.
Absolutely, and thank you for that. We are absolutely working towards shifting or changing the way we do things to be more proactive. And there are some lessons coming from the Norwich area. And also we are working with our colleagues from Suffolk, who seems to be leading on the table. So we're really looking to learn from everyone who is doing well. We've got our 2 weekly meetings, which is the delivery group, which brings together all the localities, and all the information is being shared for learning purposes. And I think we are fortunate in Norfolk and Waveney. We've got Steph, who is leading on this piece of work, and she's really fantastic on this. And she's meeting with all the localities to share good practice of how Norwich has done. So it's really good. And she's met with the clinical nurses that are working in West Norfolk around to share that good practice. So yes, so we've got a wonderful resources to do. I'm excited about next year, because I think we are in a good place now. We are closing down on the tables in the region. So I'm excited to be reporting in Q1. I think it will be a strong position.
Thanks, Tracy. John?
Yeah, thanks. So I'm building a bit on Tracy's point there as well. I suppose my concern here is that the target is an artificial one in a way, isn't it? 75% by 31st of March, and then you kind of stop and start again. But presumably from a patient perspective, it's when will we have achieved a recent health check for 100% of the patients on the register? Even if that's 15 months, say, from the start of this year, that will presumably give us more assurance that actually all the patients have been reviewed, especially having come through a pandemic period where some people could potentially have been waiting several years, I would have thought, for a health check. So I'm keen that we don't try and hit the target and miss the point, I suppose, to use a hackneyed phrase, that we do report as well on actually 100% achievement of the whole cohort over a period of time. Because otherwise my other concern would be, is it the same 75% that would get the health checks every year, because they might be easier end of the cohort, if there is an easier end of the cohort, if you like, and it's the harder to reach 25% that might never get a check potentially. So I suppose they're my concerns.
If I can quickly respond to that, and really thank you for that, John. I think I feel like I've done a disservice to the discussions that our delivery group is doing, because 75% is a national target, but our ambition is 100%. There is background papers that we will be sharing at some point, I think in April, around our intentions, which is way beyond 75%, and how we are going to do that. And it's still going through those internal discussions. And we've got plans around that 25%, which obviously, John, you will be able to see before probably it comes to here for your guidance.
Good, thanks. Bill?
Thank you. I wanted to just say congratulations, really. It's nice to see some movement on this. I mean, it's historically been a difficult stat, and I'm really heartened to see the progress that's been made in a relatively short time, and I look forward to next year. But with some focus, it does show that we can make a difference on some of these, and this is a particularly inarticulate and vulnerable group of people. So it's really great to hear that some progress is being made.
Thank you, Bill. I have to admit it's indeed a quite different story compared to 12 months ago, so we should clearly see those positives. Ahead of this meeting, I suggest to Sadie to bring this back, and for now that the month we were thinking of is the May Primary Care Commissioning Committee, because you will know the full actuals, and by the sounds of it, Shepard, you have already some ideas how you want to attack next year. So we could look back on how well we've done and sort of how we work the coming financial year, and have it more spread out, as Tracy said, and address hopefully 100% maybe in 15 or 16 months. So maybe we can include that in the action list, or in the forward planner for that reason. Any other question or comment? If not, oh, Kathy.
Sorry, late hand. Yeah. My questions were very similar to Tracy and John's, but I just wondered, when we have the paper setting out the way forward in the future, is there any chance of getting any service user experience data in there? Because it would be really helpful to see given that we've become more sophisticated, beginning to measure the impact of these assessments, and what kinds of positive outcomes there are for this vulnerable group of people. Thanks.
Yeah, thank you for that.
Yeah. Excellent point, Kathy. Many thanks. Good discussion. We move on to item 8, and we stay with you, Shepard, around the CQC summary ratings. I think, John, I believe you were amongst one of them to prompt, can we see the bigger picture around the CQC ratings, not just the ones that don't come out too well. Over to you, Shepard.
You may wish to continue speaking while I open the paper.
Well, it's on page 40, or it starts on page 40.
I'm getting there. Okay, fantastic. Thank you. This was really an interesting exercise to do with the team, to actually look at how are we doing as a system. And we thought it would be really helpful, as suggested by committee members last time, that can we look a bit broader and compare with other parts of the system, which we did. And what you have in the paper, if I can probably, oh, which page is this? Okay, if I take you to the locality CQC rating space, if it's okay, can I just check if we are there? So I want to talk from that space to start with.
That's page 41, I think.
So we have 105 practices, surgeries in our patch in Norfolk and Waveney. And you can see there's a small table there that just shows you the distribution of where all the practices are. And it looks like they're just about equally distributed across. And on your left, you've got the rating, which shows how practices are doing in each locality there. So I will start with where we've got a red, which is okay. I'll start with the south locality because I think the bright color there attracts me to start there. So in that practice, you've got 3 outstanding practices. Then you've got 1 practice that is rated as inadequate. And I'm really pleased to say the 1 practice that it has got a red rag rating has now been inspected by CQC, and from inadequate, it's now a good practice. It's been rated as good. And that's really remarkable hard work that has gone into that practice. And we'll talk a bit more when we get into the practice at risk to just illustrate that. But a lot of hard work has gone into that practice to get to that. So that means that from the south locality will have outstanding and good practice only, which is really good to see. Then just to highlight, West locality has got 100% of its practice rated as good. But there's something to note, there's a caveat there to note in terms of when the inspections were done. So roughly about 70%, if I'm right, 15 of 21 practice have not been inspected within the last 5 years. So that's something that leaves us with some proactive work to do to ensure that this part of the system received the support and the learning that has taken place in other parts of the system. So we're quite conscious about that. We're quite aware of that. If we move to the north locality, 1 practice has been rated as requires improvement, whilst the other ones are outstanding and good. Trying to think of which practice is that, but that will surface in the practice risk in our discussion, so I'll be happy to do that. Norwich, I think what is peculiar about Norwich is it has received a lot of attention from CQC in the recently than other parts of the system, and they have done really well. 95% of the practice rated as good. Okay, so moving on and trying to look at how we are doing against the West Suffolk areas. So you've got a pie chart that has been put there just for your information, just to see how we compare with others. But whilst we're trying to compare this, it's not an easy comparison because of the size. The scale is different. So there are about just less than 25 practices in West Norfolk, but it just gives us something to work with and also to see where there are opportunities to learn and share practice. I wanted also to share some themes. We tried as much as we could to try to make sense of the CQC inspections in terms of what can we learn, where it's outstanding, what are the issues in that. So you've got that table there. but it's the distinction between that good and outstanding. The issues seems to be similar across in some ways. So medicine's issues. So it's an issue of continuous improvement and trying to master good practice there. But it's interesting when you look at requires improvement. I think medicine seems to be a common issue across those areas. And also issues around governance seems to be quite strong where requires improvements. Then on inadequate, I think I'm noticing that leadership is missing in there, but that is one of the big issues that we've also seen around inadequate providers. So I'll stop there, and if there are any kind of remarks or reactions or comments that colleagues would like to make.
Yeah, excellent. Many thanks, Shepard. Tracy.
Yeah, thank you, Shepard. I mean, that's really insightful, actually, to have that overview. So I'm particularly struck by certainly thinking when there is that improvement and that inadequacy, a lot of it is around the leadership, but it's around the medicines management, the prescribing, the storage, the safety, which I think, you know, as a system, that there's hopefully a lot we can do about that with perhaps, you know, learning events, sharing and various things. So I think that's really helpful to know that, and hopefully something that the PCNs themselves can embrace. And I know Chris might come in because we're kind of looking at work across the system respect of, you know, quality and safety in primary care. So I think there's some key things we can do together, which I would be very supportive of.
Yeah, thanks, Tracy. Chris. I can't hear you, Chris. Sorry. Oh, I get noise.
Hopefully you can hear me now.
Yeah, I can hear you.
Yeah. Yeah, so sorry about that. Yeah, I was just going to say the table is really helpful, looking at the trends and themes, Shepard, from with the ratings and what the themes are. I think from my point of view, as I mentioned last time, I think that'd be a really good starting point, as Tracy said, to look at putting on some different lunchtime events for primary care, and certainly that's something that my team would be really happy to work with you on, and also Michael's team in medicines management. I think that'd be really valuable.
Yeah, excellent suggestions. Thanks, Chris. Peter.
Thanks. 2 points following on from, I think it was Tracy who spoke first, and similar to Bill's comments on the LD checks bit, it's really helpful to see that system overview piece. I still consider myself relatively new to Norfolk, and of course we've a vested interest in the quality performance level of practice because we do commission some services with practices, and often obviously we sit here looking at where there's been a adverse inspection of the CQC, so actually to see that very high level of good and those few outstandings as well is a really helpful context. I guess the bit, and it isn't necessarily for here, I'm very happy to pick it up outside, but it's to try and increase my understanding of where that sits us proportionately in terms of other areas, first of all, and also if you were a layperson looking at this entirely afresh, one might take a view that in the areas where we can get every practice to being good, no one is less than good if you look at the West. But in those areas where we have the 1 or 2 outstandings, we also have the 1 or 2 failings, as it were. And I don't know that there's anything to be learned from that particularly, but it strikes me that if we can get that sea of good, then that would be, you know, that would be quite something, because clearly we're almost there. And it, you know, to get that system overview, I think has been really helpful after numerous of these meetings where we're concentrating understandably on the ones that aren't doing so well. Thanks very much.
Thanks, Peter. Kathy.
Thanks, and thanks, Shepard. I mean, I can see a lot of work's gone into this paper, and it tells you some really interesting things, and in other ways it doesn't tell you anything much. And I guess kind of my observations are that what the paper really told me was that CCG rating is quite a blunt instrument, isn't it? Because it might mean something one year, and then, you know, stop meaning something as re-inspection hasn't happened. And I think the information about the sort of time lags and when people were inspected was, for me, one of the most marked parts of this. So if somebody's outstanding in 2015, they could be shocking now, but we don't know that. And so it just struck me how important the additional work that you do around CCG oversight is, and how that kind of almost provides a safety net to the CCG, which is a line in the sand at a point in time, isn't it? Sorry, too many. And I guess then the other thing I wondered is have there been changes to the CQC's focus over the years? Because I mean, in my experience, I think there has. I think, you know, maybe they've become more sophisticated. They've certainly become much more focused on the process of managing medications, haven't they? So again, the time lag therefore is important, because it's not to say that those people who haven't been inspected a long time ago are going to be good at these things. So I guess so I'm rambling a bit, but for me, the themes were the most important, because that is what you're going to be measured against now, if you like. And then my final comment was the graph on page 42 of the pack on the West Suffolk practices, recognising we have a different demography and many more practices. If we had that graph on us, how would it look? So those were my comments. Thank you.
Thanks, Kathy. And points to take away for Shepherd. Sadie.
I just wanted to reassure Kathy before I bring my point in that actually Shepherd and I have been talking about exactly those points, and it is forming part of his team's work programme for next year, which we're already working on developing. But my point was just to point out, I'm sorry, Shepherd, that I didn't spot this on first read, but somehow it jumped out at me on second read. On page 46, you've got the Kirkley Mill surgery at the top, and they are on the chart rated as requires improvement overall. They're actually good. They were a practice that had been rated requires improvement for quite some time, but at their most recent inspection were rated as good in the focused visit that they had. So they still have one item of one domain, which is RI, but overall they're good. And I just wanted to point that out, as this was a meeting in public.
Yep, thank you, Sadie. Rosemary.
Yeah, I was just going to follow up on a point that you made, Kathy. I think there's no doubt that the CQC inspections are a little bit of a different beast now than they were 5 years ago. I think there's a lot more of behind the scenes data gathering than there used to be. I think the actual inspections themselves, I'm hoping, are a little bit more objective than subjective. So I think the actual process is different and hopefully tighter and maybe just a bit more streamlined. So I think, as I said, the figures are all useful, but you do have to bear in mind, I said inspections are quite different now, I think, and I think the focus is on different areas. So it'll be interesting, because I'm presuming those areas that have not been inspected in the last 5 years, as we get back to a more business as usual model, we will be seeing the CQC coming round. So in another couple of years, it'll be quite interesting, you know, to see where we all are.
Indeed. Thanks, Rosemary. Peter?
And not dissimilar from Rosemary's comments, actually, I was going to say, you know, it's an active conversation. It has been for my 15 years as a healthcare commissioner. Are we, if you like, taken by surprise with the outcome of a CQC inspection on a provider, and how could we have foresaw, or how could we have known what the CQC would see? But I think it is important to be clear that as a commissioner, we don't have the access of a regulated of a regulator, a statutory regulator, but I do think it's worth, and clearly is, continuing to strive to have those local processes and measures and sort of smart metrics and things in place that we can get an idea of what a CQC inspection or a regulatory inspection would would come to as their sort of view. But it is a very different regime. Thanks very much.
Yeah, thanks, John.
So just a brief comment. I wanted to thank Shepherd and the team for the work, and for me, it like you said in the introduction, really, it's helpful to get the context because we always focus on the practices that are struggling, don't we? But from my reading, this is, I think, 100 out of our 105 practices are either good or outstanding, which feels like something to celebrate. The concern I would have, I suppose, just mirroring what others have said, is the fact that obviously a number of these assessments are now significantly out of date for understandable reasons. So it's really positive, but I suppose a question mark about what level of assurance we can put on that. But others have covered that already. But thank you.
Yeah, thanks, John. Rosemary.
Yeah, I just want to come back on the point about what to expect with a CQC inspection, because I think one thing that it's worth noting, which I think has been really positive, is that the CQC have been much more willing and ready to share what they will now be looking for in inspections. There have been some very good webinars, etc., for practices to give them a flavour of what they'll be looking for, the data sets they will be examining prior to coming, the drug searches they'll be running, all of that sort of thing. So it doesn't feel like quite such a cloak and dagger thing as it did before. It's a much more collaborative, we're not coming to catch you out, we're coming to help and support you. And I think that has been a shift from the first round of inspections. So with, good viewing of the CQC website, etc., there's very helpful tools on there as to enable practices to really get quite up to speed before a visit and ahead of the game, if you like, to really know that the areas that they're going to be focusing on. So I think that's kind of helpful and sort of reassuring as well.
Yeah, good to hear, Rosemary. Shepherd.
I just wanted to echo Rosemary's observations and comment, and it's really good that CQC are taking a more system-wide approach, and they are communicating with the practices and providers, and they've done a recording of their approach, and that information is circulating. And the feedback from providers that have been inspected is really positive. And I believe that we are more working like a system, and there will be less surprises in terms of what the outcomes are. I think the issues are there, and we'll recognize them, and we'll work with practice proactively to address those. And I think I'm positive about the practice visits that we are looking to bring forward in this coming year that would complement the system, including CQC, in terms of the work that we are doing. So that would provide assurance to ourselves and provide the assurance to the wider system about the work that we do.
Yeah, let me just briefly echo that. I think Kathy referred to it as well. There is this safety net that the CCG proactively reaches out to practices, and it's not in the public part of the agenda, but in part 2 we do have line of sight on practices which may need support. So we're not purely reliant on this aspect. Peter.
I don't know if it would be appropriate from the chair of this committee, but having worked at a statutory regulator, it's not very often they hear that they did something very well or that they've been very constructive and supportive. So I would encourage the CCG to maybe echo those words to the CQC, whether it's a letter from the chair of this committee or through some other route, because often it is the negatives that we speak about when we think about statutory regulation.
That's an excellent suggestion. I'll take it up with the chair of the meeting. Thank you all. Good discussion. Again, Shepherd, kudos to you and your team for putting this together. We move on to item 9, which covers quite a bit of the pre-read in number of pages. There's actually 2 documents, as you may have seen. There's access to general practice in Norfolk and Waveney starting on page 51, and access to primary care for BSL users starting on page 82. And these come from requests from the HOSC. So I'll hand over to Fiona to give an introduction and then open it up for, I'm sure, comments and add-ons that I think the CCG team can take forward. I should add the note on BSL is together with NHSE prepared. I'll hand over to you, Fiona, for an introduction.
Thank you very much. I will largely take the GP access paper as read, but I just want to make some few comments on the BSL paper.
Yep.
As updates since the paper was written. We are continuing to work with practices around the AIS, which of course is much wider than those covering deaf patients, which we do recognise. There was a Healthwatch England webinar last week launching their report around the AIS and the concerns that have been raised with them. And from that, we've learned that we are expecting a report from NHS England by the end of this month, setting out first steps at high level about how to improve patient access and making a number of recommendations. And there'll be further detailed guidance to follow on that. So obviously any work that we do locally, we want to make sure that we pick up that work once the report is published. And we're also expecting some updates to the Accessible Information Standard from June, as I understand it. And NHS England have been working very closely with CQC because much of this is actually picked up in their inspections. And also, I just wanted to share the fact that we've had a lot of positive feedback from practice staff who have taken up the offer to do BSL training. They've really enjoyed it. I'm really keen to actually start using it, which I think is really positive. And we've got lots of learning which we're starting to pick up, which practices are now sharing, such as having deaf champions. And we've also got one practice who have had their name badges translated into sign language, which we think is it's just such a simple action, but hopefully will help patients to feel welcome in surgeries. And the final thing I just wanted to add around that paper is we're finalising the local commissioning plans, which are referenced in the paper for what happens beyond April around enhanced support. And we will be asking for Chair's action by the end of March if this is acceptable. So I'm happy to take any questions on either of the papers. Many thanks,
Fiona, and many thanks to you and others who've worked on these notes, because it's a considerable amount of work. I fully appreciate that. So any comments or questions which would be helpful to the team as they sort of prepare for the HOSC meeting itself, which is later this week, actually? I'll open it up. Peter?
Thanks. I am conscious of the comments that have been sent outside of the meeting by the LMC, and I'm sure they are noted, but just to sort of acknowledge those. It may be felt that this is covered, and I'm conscious that the LMC didn't explicitly raise it from my reading of their comments, and so it may be a resolve point. But one of the things we've talked about in this forum before is whilst physical attendance at primary care has bounced back and is sat above the national level, there was at least a period of time when we weren't sure if we were matching quite apples with apples, in that we felt that some proportion of attendances was new activity in primary care, i.e. activity that was maybe being redirected from secondary care and having to happen in the primary care setting. And so although the absolute number of attendances had returned, was that the same form of attendance, if you like, as primary care would have been dealing with pre-COVID? And so I guess I just wanted to check in that we things are stable. I don't quite know the question I'm asking, but things are stabilising, and that we do feel that primary care are back dealing with a similar, same workload, if you like, as they would have pre-COVID if we continue to see that diversion and disruption. Thanks very much.
Thanks, Peter. Fiona, can you speak to that?
Yes, thank you, Peter. I think it would be fair to say that the data does reflect the same patient contact along the whole journey, potentially. It depends how individual practices actually record. So, for example, a triage followed by a face-to-face appointment, etc. So that data is difficult to break down. But I certainly feel, and the paper was prepared in conjunction with colleagues, general GP colleagues, that primary care is very much open for business. There were certainly challenges in December and early January, as you would have expected, and that's why we've not used that activity, but certainly we're seeing the activity very much stabilising, I think, and I think that's reflected in the graphs that are shown when you take away the COVID vaccination activity. And the proportion, the proportion of telephone to face does go up and down. There's no doubt about it. But the ultimate decider, and colleagues in general practice, I think, would agree with me, is patient choice, and giving patients what they feel they need. And a lot of patients will welcome online consultations, and that allows time to be made available for patients who do wish to have face-to-face appointments.
Thanks, Fiona. Tracy.
Yeah, it's building a bit on what Peter's comments were. So it's just wondering with the context, if they're actual contacts, are we counting particular contacts more than once? Because, you know, certainly I'm a primary care clinician. I know that I have, if you want a better word, frequent attenders who come again and again. So it's always, to me, some of the new routes of kind of accessing primary care virtually going to be accessed probably by some individuals a lot more than others. So it's just how are we counting that? How, you know, and are there kind of members of communities that, for whatever reasons, we aren't seeing, we're not engaging with, they're not coming to us? Because to me, as a clinician, they're the ones I worry about the most. You know, they're the ones that might present late with you know, cancer symptoms, various things. So to me, there's a bit of work about that to really understand this data. And I think it's also, what's the experience? I don't see reflected in that. What's the experience of the patient, the community, the population? What's their experience in all of this? I don't know that necessarily we've captured that for HOSC or generally.
Fiona?
Thank you, Tracy, and I think that they're very good points. The information that we have is provided by NHS Digital, and it's only practices who have access at a more granular level. So I think it's important for us to work with our practices to understand perhaps where the demands, as you say, where the frequent attenders, and how they can be supported. And I think that's probably a different discussion, but absolutely a really important one. And your point about health inequalities, absolutely, there's no doubt that there is a different set of challenges that we now face. And that, I think, is reflected in the fact that one of the key priorities for PCNs this year and next year is around health inequalities, and making sure that primary care services are accessible to all patients in the way that they need to access services. But certainly we're not there yet. There's a lot of work to do, and we need to make sure that we can work with our colleagues in primary care to support them to do that, and also perhaps think about how we measure those outcomes. And of course, there will be the next GP survey, which will play an important part in looking back and comparing those outcomes.
Thanks, Fiona. Kathy.
Thanks. Slightly unpopular comment. I can see that this is a really well thought through paper, and yet reading it, I kind of got the feeling that there's a group of people saying things are not okay, and this paper goes, oh, here's all the evidence to show you that everything's fine. And that made me a little bit frustrated, really. And I guess when you look at the top of page 66, it says we've had loads of complaints, this many complaints, a number of them about access and appointments, but there's no themes. And then it doesn't say any more about that, and then goes on to say that, but we're not going to tolerate abuse towards our staff. And I just wondered, some kind of linking sentence to say, however, we recognise that there is a lot of strong feeling out there. People are being, are feeling frustrated by the changes. Tracy's population of people who don't access primary care. One of the local, old cat and life sites that I'm on, people are rampaging about how they never bother to go to the GP because it's just a waste of time. And whether that's based in fact or not, I think there needs to be something in this paper which simply recognises that A, changes in the way people work, and B, the enforced changes by the pandemic have given rise to kind of lots of high emotion, and we're seeking to address that. And because the paper is so factual, it made me think that we haven't actually paid enough attention to why it's, why the paper's been written, if you will.
Thanks, Kathy. I'm not sure if Fiona needs to react. I'm also conscious that partly response to actual questions put forward by the HOSC, so I think the format drives that, but I think your broader point and the one Tracy's made is well understood. Andrew.
Yeah, thanks. Trying to provide some answers to some of that from a Healthwatch angle. We've had a lot of conversations along this line, and it is all anecdotal. So it's people that put themselves forward to express a view. I think it comes down to two issues that we've discussed before, and that is, one is a large number of people simply do not understand and frankly feel a little bitter actually about the changes that have been made, which were of necessity, but if we're honest, this has been the way things are leading for several years, and they feel not consulted, and they feel that they haven't been taken along with those changes. So it boils down to they don't understand, some people do not understand what the whole idea of triage is and why they can't just get through directly. That's not new. But there's also a significant minority of people who welcome being able to access online healthcare. Of course, that tends to be the younger and more capable and more IT literate groups, and they think it's brilliant. But the people that are most vulnerable, so not all the elderly, not stereotyping elderly people, but generally older people, or also younger people who don't have good IT access, who are poor, who drug addicts, and there's a group of people who simply don't trust any form of online activity because of paranoid feelings about government monitoring and things like that. It's become a worse service, I'm sorry to say, and I hate saying that, but I think we've well understood that, and yet that paper, it produced, as Kathy just said, produced the factual rebuttal, but not at an emotional level, and that's what we get. And I went to a surgery recently to have a chat with some patients, and they were frankly quite angry, not with the individual clinicians that they're seeing, but with the, as they see it, the broader system that they feel has been stolen from them, frankly. And the other one, just to say quickly, we've also addressed before, is people have virtually no understanding of all the other health professionals. So it still is, I want to see my doctor. They don't know about all the other professionals that are there. And we've still got a huge communication and education task, I think, to do, which was started well before Christmas, but that's gone very quiet. I don't know where that's all gone. Anyway, nothing new really, but just to reinforce what everybody else has said.
Yeah, thanks, Andrew. Bill.
Yeah, well, I agree with a lot of what Andrew's just said, actually, is how do we know people are happy with where we are? Because I don't see us doing any quantitative or qualitative work on asking people whether they are happy or not. And it might be helpful to do some focus groups or something, just to have an idea of where we're making progress and who is happy, and if there's any way of categorizing those sorts of people and the ones who are not happy, so that we don't then have to hit a massive blanket solution for everybody if we have some quite specific groups who have specific problems, and that makes them unhappy with the whole thing. It just makes solving the problem smaller, in that, you know, there might be a very large chunk of people we don't need to do anything to at all. So as a system, and I suppose that's where we sit in this meeting, I think it might be helpful to just do a small piece of work, and this isn't something that all practices have to do, just to give us some information to then help focus practices, or guide them in terms of that. Because the one thing I wouldn't want to see is a whole new set of forms for everybody to fill in. Because I know how popular that would be, you know, and then somebody would have to collate it all and everything. But I wonder if there's a lighter touch way we could just suck some information out of this.
Yeah, thanks, Bill. Sadie, I'll come to you in a moment, because then you can sort of reflect on everything they've heard. But I'll go to Rosemary first.
Yeah, just anecdotally from within general practice, I mean, one of the barriers that people perceive as access, unfortunately, is the websites that are now provided by Silicon, our Footfall website. They're challenging. A lot of practices have adopted Footfall with Silicon, the company that runs Footfall, have taken the Silicon website as the access into their practice, their online website. And it's not ideal. It's not terribly user-friendly. It doesn't tend to reflect the individual practices as such. And I know for our patients particularly, it's rather a Marmite tool. You either love it or hate it. If you, you know, if you're very IT savvy and you can find your way around and you understand what all the rooms mean and how to access what you need, it's good. But for a lot of patients, it's perceived as another barrier. And it's not popular. And the problem that we have, certainly at the ground roots level within primary care, is we're unable to actually really change that website without going through Silicon to do it. So we can't make those little intuitive changes that we might do, which would have helped actually with communication with patients. A lot of that has to be done with Silicon. Now they're responsive, don't get me wrong, they are, but it's not the same as just sorting out your own website and making your own adaptations. And the point that you were making, Andrew, which is a really valid and pertinent one, is about patients not knowing what all these other people do in general practice. And as we get more of the ARRS roles coming through, you know, it'd be lovely to be able to really promote those on our website, tell patients a bit about them, all of that sort of thing. And it's just not so easy now for those of us that have used Footfall and use the Silicon site. It's just not so adaptable and flexible as we'd like it to be.
Thanks, Rosemary. Sadie, you might have had a pertinent point, but maybe you can also reflect on some of what you've heard so far.
Thank you. Yes, and it's been an incredibly constructive discussion, so thank you very much for that. I think from my point of view, I think we well recognise many of the points that have been made today. I mean, on a grand scale, we know that every month, roughly half of our or the equivalent of roughly half of our population, 600,000 or so appointments are happening. So, you know, it's a huge amount of activity, 30-odd thousand appointments every day happening in Norfolk and Waveney. And for the vast majority of people, they're probably quite happy. But as Tracy has pointed out, nothing is perfect here, and perhaps the most concerning thing for me is the fact that the people who probably most need our support are the ones we don't necessarily pick up in all of that work. And I think certainly our focus going forward is really to try and understand and get underneath our health inequalities data, think about how we can better engage with people. We do have a role in the team which unfortunately has largely been focused on COVID vaccinations as over the last few months for obvious reasons, but really trying to help us with our campaign to get better understanding of the new roles in general practice, and really trying to help us to reach out and understand the needs of our population. And I think, you know, I absolutely agree with Kathy and Tracy. Until we understand that, we don't really, we can't put our hands on our hearts and say we've got it completely right. And I think we do acknowledge that. And then, of course, you know, when we do have that information and we can prioritise how we approach those areas, we're likely to still have a contingent of people who are dissatisfied with the service because they want it to be different. And I think somebody, Andrew, mentioned about still wanting to just see the GP. So I think, just to summarise from my point of view, really helpful discussion. I'm pleased that many of these things are already part of our planning, and we'll be able to, you know, over the coming months, start to bring our thoughts to you. We've started some of the early scoping discussions, particularly based on health inequalities, and we'll be really pleased to bring those back for further discussion in due course. But yeah, thank you very much.
Thanks, Sadie. John?
Thanks, Hein. Sorry, I just wanted to pick up on Rosemary's point, if I may, just very briefly about Footfall website, just because I was speaking to the digital team a day or two ago, and they were saying what good feedback they were having actually from practices and patients on the rollout of the new streamlined interface for the website, which I think has maybe improved some of the things that people were flagging before. So just think that it's probably reflecting, as Andrew and others have commented, that there's an element of sense of Marmite about usage of digital solutions. So just want to say that there has been some good feedback on that as well. So it might be worth maybe asking, there's probably a digital update due at one of these meetings soon, so it might be worth just picking that up as part of that next update. Thank you.
Yeah, thanks, John. Rosemary?
Thanks for that, John. When you say the new streamlined digital interface, what exactly part of the website are you referring to when you say that?
I don't know the technicalities, Rosemary.
Right.
I just had a conversation about the fact that there was a new streamlined version that had been made available, something called Evolution.
Right.
I think, but
Okay, all right, interesting. Thanks for that. Thanks, John. Thank you.
Well, thanks, everyone. I agree. A good discussion. Maybe, Sadie, it would be helpful, because I think it will be Mark Burgess and Kath Byford who will go to HOSC to share this feedback and compliment them on the note and the facts, but sort of complement that sort of the experience side and the emotional angle that Andrew refers to. It would be worth if they include it in their introduction to sort of maybe preempt some of the sentiment that the HOSC may have. And maybe I can ask, given that we've had this note, maybe to hear next month from the feedback they received from HOSC. I know the LMC put a note forward. Also good to get feedback on the BSL access note. So thanks, everyone. We'll move on to item 10, locally commissioned service. I believe Gina is on the call. Gina, happy for you to introduce and then take questions.
Thanks, Hein. It's Gina Cooper, Senior Manager for GP Resilience. I apologise now, I've got a shocking cold. My voice is not good and I'm sucking sweet. So if I break off coughing, then Sadie has kindly said that she'll pick up for me, but I'm hoping to hang in there. So thank you for reviewing the paper that was submitted within the mail out. We are in a position now at the LCS review of looking at mobilisation. So I just run through the very quick headlines of the paper and pick up one or two elements that may have been updated since we've written this. So as we said, of the 12 LCSs that have gone out, we've had fantastic response from practices. I'm so pleased with the way that have come through. All 105 practices are signed up to a majority of them. And as I said in the paper, we have a number of work streams where there is 100% sign up commitment for delivery, which is fantastic response and actually shows how reactive and ability to change that our general practice has at a time when they're under significant pressure. So I'm very grateful to them for those areas. One or two of the bits I'll pick up with regards to the points that they haven't got 100% sign up for. Phlebotomy is just about there. We had one finalised sign up and we have got that now verbally agreed. So that's fantastic news. We'll pick up more about that later in part 2. Spirometry, we had 5 practices discussing. We have had one already decided they want to sign up. Some of the hesitation with regards to this is around IPC, the Infection Prevention and Control, and we have meetings with both our national and our local infection prevention control teams and our practice nurses, kind of getting down to the nitty-gritty of what a toolkit of restart actually means, and to overcome those concerns. It's great when we send out papers about what to do, but when we have then reaction from practice that says, actually, I still have this concern and this question, we're basically running through those points now because we want to take them on board. If one practice thinks that you can guarantee at least half a dozen more do. The other elements for this will be picking up is the eating disorders. We have our mental health commissioning team working really closely with practices at the moment to pick up there. We've had 3 more sign up since this paper was written. Some of the hesitation with the signing up initially for eating disorders was to do with historic belief of the specialist services and historic understandings of things that used to happen. And again, it's very difficult to keep up communications, but our specialist teams have done an awful lot of work to increase the assurance and the provision of services by our specialist providers. And this has now been conveyed on a one-to-one with those practices who are hesitating, and they're assured to sign up. So that's also good news. With regards to, sorry, my voice has gone. What was it I wanted to talk about? Apologies. Oh, the inclusion health. And that actually ties in the conversation we had earlier on with regards to accessibility and inequality. All practices are signed up for the 100% sign up for the inclusion friendly element. Now, this point is actually to work with our primary care reception teams to encourage them as to how patients who don't necessarily want to complete through the digital interface can access our general practice and how they can communicate, register with and actually access the services we have. So that's workload going through using the toolkit of Doctors of the World for safe surgeries and frontline training. So that ties in really well with the element we've just been talking about. In fact, all practices recognise this as a key issue is really good news. Work that's currently underway is very much along the lines of the patient engagement. Now, Andrew, I know that we've had conversations around this previously, and something that we knew was lacking due to the pace of which we were moving is to be able to go out to patients and engage with change of services. This is now out there. There is both digital and paper access for patients, and it's very much along the lines of the LCS reviews undertaken. We understand that there's 1 or 2, and it is literally a couple of services that will result in change of pathway, which will directly affect patients, and to kind of really understand the additional materials that they may need and support they may need in order to be able to access these changes. On one of those areas is that to do with earwax removal, which we know is something that patients enjoy having in their practice, and because of clinical prioritisation, we're moving the service away from a frontline GP practice provision through self-care to a specialist community provider. So we are working very hard with our comms team at the moment, and we have to have the leaflets out at the end of the week around how to improve self-care and to enable the patients to access that change of service and how to access through that element. The other points to pick up is to do with enabling our practices to report and capture the workload that they're going forward. Nationally, there's a system called Calculating Quality Reporting System. Something's been in general practice for a number of years, and it's usually used for national DESs and designated enhanced services in order to go through and capture activity. So we are one of the first CCGs to undertake a suite of services to go through CQRS local. The benefits of practices will be along the lines that they don't need to undertake additional workload as far as raising invoices go and to undertake additional searches and reports. It's a way that we blends in with, they'll undertake one process through their clinical systems, run a report, upload the information into a system that they already use nationally, and it automatically ties into our back end of the CCG for finances, and they'll get paid automatically based on the workload and the outline that we've already provided for them, whether it be activity block or item of service. They'll have a complete handbook going out for the end of the month about what's involved, and then because the first submission for this won't be until the end of the first quarter in June, and recognising the pressures that practices are under currently, training for these will go out in April and May time, when it's traditionally, I'm going to use words traditionally, it's slightly easier in practice to undertake new concepts at that point. So that's well underway. And we continue to meet with the LMC on a weekly basis to tie up all the loose ends. So going forward, things what we do next, the contracts will be raised imminently. Now, we had a delay on raising the contract for practices because we're waiting for the release of the national framework, which came out end of last Friday. So that's now being worked on by a procurement team, and they'll be raising all 105 contracts to go out to our practices. Each contract will include the details of the 12 LCS specifications, which we are including. We've continued to go through and work with them, communication in the Teams channel. And the final element to kind of really raise with you about mobilisation is that we recognise really strongly to get the best out of these enhanced services, we need all practices working the same way, capturing the same data and reporting that data in the same format. And this very much ties into future commissioning decisions. So we're working with our clinical templates provider at a very granular detail at the moment to make sure that what we had intended to commission is going to be captured through templates, and then it's actually be reported in a single reporting tool that's enabled by all practices. So we're not asking practices to, as we have historically, to write their own searches and outputs. We'll be doing that for them, and we're midway through that process. Finance accountants amongst you will be very pleased to know that we are also going through and working on a quite granular basis to enable practice to understand what they need to invoice and report when. So the invoicing will come through the item of service element, which will be mitigated through. We're also going to issue them a schedule around what they can expect, what their thresholds are, because we've built the 15% activity detail in, as for those of you who remember reading the specs will include, and then going forward, when they can look at having their rebase lines and what the impact would be. So we still have a lot to do in the next 3 weeks, but majority of it, I think, is well underway. Open for any questions and comments. Thank you.
Many thanks, Gina, and also for the latest updates. Any questions or comments for Gina? John.
Just want to say it seems a fantastic outcome, Gina, just given the bit of a patchwork we've had in some cases in the past for some LCSs to have 100% phlebotomy, to have nearly 100% for eating disorders and things like that. Just seems a real achievement. So really well done. Thank you.
Thank you. We're almost there.
I think you've silenced everybody else, Gina. I can only echo what John was saying. Tremendous achievement by you. Good partnership working with the LMC and engagement with the practices. So very good to see. Many thanks, Gina. We'll move on to item 11. I think Molly has joined for the Norfolk County Council Healthy Behaviour Change digital offer. Just checking you're there, Paula.
Hi, thanks very much, Chair.
I'll leave it to you to introduce, and then we'll open it up for comments and insights you're keen to get from the committee members. Over to you.
Thank you. Yes, my name's Paula Hawley-Evans, and I'm consultant in public health with Norfolk County Council, with the lead for health improvement. So just wanted to talk to you today about NCC's Healthy Behaviour Change digital offer that we're currently developing, and talk to you about the opportunities for its use, particularly in support of the discussion that you've had earlier in this meeting around the primary care strategy, digital enabling primary care, and also supporting people in the community, which I think it really links into. Just by way of background, NCC developed a healthy lifestyle approach, which was agreed by Cabinet in 2019, which was pre-pandemic, so hence some of the delays with some of this work. But the idea was to have a systematic approach to health improvement, which would have a number of elements: a digital offer, a behaviour change training offer, and working with the community to engage them, and that would link with the range of commissioning services that Norfolk County Council provides. So people will be familiar with Smoke Free Norfolk, the Slimming World offer, and things like Man versus Fat. So together it would be a whole package that would really focus on how we can support adults who want to make changes in their behaviours. And that would focus on the 4 high-risk behaviours around smoking, obesity and diet, physical activity and alcohol. So that offer is really around looking at resources for the individual themselves as they want to make changes, and also for anyone who wants to help them make those changes. So that could be any primary care staff, social prescribers, wellbeing champions, a range of people. And the idea is really that it's a bit more than just a transactional information website. It's not just giving that information, it's about seeing it almost as an intervention in its own right, helping people to understand what behaviour change means, looking at their motivation, goal setting. So there's a range of resources on there. And it's based on behaviour change science and has been put together by experts, input from UEA and public health colleagues. And each elements have been tested, you know, with various cohorts of people and the public. So there's quite a few more details in the paper itself. I'm not going to go into all that and on all the content. But in summary, really, it's just about giving you an early heads up around this. And I know it's quite difficult when you can't see a product, but we wanted to make you aware that this was happening and its particular focus, and that we're hoping to launch it in late spring. So there'll be some links with yourself. We've just undertaken a branding exercise, so that is, we're just collating the survey results, and we've used the citizens panel and Flagship Housing as people to test that out, and hopefully we will have that fairly soon. So that's really the information in a nutshell. I think there's possibly some opportunities to link with yourselves and work that you're doing, and maybe I can come back with a preview when we're at a bit of a later stage, but I thought it would be helpful at the moment to discuss it with you and see what the opportunities are for linking in with the work that you're doing. Thanks very much,
Paula, and thanks for creating the awareness. I think you hit the nail on the head. What do we see as the opportunities to leverage this work, Tracy?
Yeah, thank you, Paula. Thank you for the overview. And it's great to see that this is here. I mean, I think one of my questions will be about those that perhaps aren't digitally enabled, because clearly kind of the reach for that might be limited, certainly for some members of our community. So, you know, is there consideration for bespoke offers, certainly for specific communities or community champions? So thinking perhaps, hopefully you'll be linking in some of the work we're doing system-wide in respect of health inequalities. We have the oversight group and particular work streams within that I think might support, you know, the kind of the engagement of communities, but kind of the awareness of this tool and how it supports other programmes of work in respect of health inequalities. So be keen that you support that. And I think also linking into, you know, our various localities. So we will have, as you know, the health and wellbeing partnerships, particularly looking at health inequalities. So again, it's that. And I'm just thinking about when people are utilising the tools, does it kind of correspond to what their offer is locally, so what's available to them? Because sometimes when you're considering aspects of perhaps motivation, loneliness, it's about doing things with other people as well. So how does that link people into their communities? Just wondering if there's some aspects of that to consider.
Thanks, Tracy. I'll just move around the block, and then maybe towards the end you can reflect on the feedback you've heard, Paula. Okay, Sadie.
Thanks. I think the opportunities around this model is that it's probably going to have a wider reach than people trying to fit criteria for a face-to-face service. So that's I think really positive. I guess it's how it integrates with the existing face-to-face offer, and how, you know, if people are unsuccessful in their attempts through trying to do it on their own, how they can then move into almost a mixed model approach, I suppose. And and how, whether we've thought about, will it divert some of the activity from the current way of offering support, which might free up more capacity, for example, for what Tracy has suggested around the health inequalities work. Thank you.
Thanks, Sadie. Bill?
Thanks very much, and thanks for letting us bring it here today. I think this is really important, and it's something that I've been, as Paula knows, very keen to see finally make the light of day, because it's a project that's been around for a while, and I think that I'm very keen to get it launched. But I am also it's not a static resource that can't change, and I think that if there are ideas and approaches that come from it, or and I'm sure there will be opportunities that previously people hadn't thought about that come out of it, that the team won't be sort of packed off and sent off to do something else. We're going to keep investing in it, so that it is something that can change and grow and respond. I was just very keen that people who wanted to make a choice didn't have to necessarily engage with the system if they felt that there was support for them, and if it then leads them into the system, or if you've got and one of the things was that if you want to help somebody else make changes in their life, that it empowers you to be a resource for the person who you're trying to help at your own time and in your own place. And so we don't know what the branding is. I'm keen to have a sort of a brand that isn't specific to Norfolk, because in some way it might seem parochial to people, and it's more about, if you're a person who wants to make a change in your life, this is somewhere you can go. So and if you've got any very strong ideas about branding, then let us know, because we haven't made the final decision yet. But hopefully now that it's on your radar, and I just say, all feedback through Paula and a very competent team will be very welcomely received.
Yeah, many thanks, Bill. One observation from my side is probably it's also useful for the social prescribing staff at PCN level to have sight of this, because some of it corresponds very much what they're trying to pursue. Maybe back to you, Paula. You heard several reactions in terms of making sure we think about those who we maybe label as digitally excluded, and let's make sure we don't exclude them in the thinking behind it. But back to you for some early reflections.
Yes, no, thanks for those really helpful comments. I think in Tracy's points in particular, we're working with our Healthy Libraries service to look at how we link with them around supporting people who want to use this. And I think that will be, quite a good link into people who maybe haven't got those, aren't digitally enabled. We're very involved in the Health Inequalities Oversight Group, particularly looking at data-led approaches. And I think, again, looking at disadvantaged communities and how we can make things much more applicable to them. And even looking at things like the Protect Now programme to see how we can work with yourselves and Rob Jackman on that to really tailor some of these services to them as well. So I think it's a really important comment that we need to take on board. And as Bill was saying, really, I think this isn't static. It is something that's going to evolve and shape. And, we really do welcome, ongoing input. And I think it will change as time goes on. I think we do see it very much as integrating with services. I think Sadie's point, this isn't just something that's a standalone thing. It will link into the commission services that are there already, and making sure that we do, if people want to go into services, that they're enabled to do so, and looking at what our support offer is to, as this site is developed and launched, that we can work with people like social prescribers so that they know how to use the site, that they can use it appropriately and make sure that people can access it. So I really welcome your comments and thoughts, and I'll take those away as we develop it.
Yeah, many thanks. Peter?
Thanks. I'll just add a word or two to Paula's bit there, picking up on Sadie's point and Bill's point as well, that some of the physical services that are outlined in Paula's paper actually mark new investment and growth in our physical provision around healthy lifestyles in the last year, not least around the Man versus Fat programs and such. And we absolutely will be continuing with those. And as Sadie suggests, you know, if anything, what this does is free up some of those resources where people who would prefer and can engage online to support some of those who maybe aren't able to for various reasons. And actually has a common thread with the primary care conversation we were just having through the HOSC paper, that there will be people to whom the physical attendance requirement is a barrier, and they will prefer to engage with a digital and online platform. And along that line, to repeat again, not a fixed resource. We do have a budget aligned to this recurring. It's not just about pressing go and the platform's launched and that's it. We've got a continuing sort of development budget around that, so that we can adapt and shape this resource. And you know, what we expect from a digital resource will naturally change in time anyway, in terms of how clever our systems can be. And so we'll, you know, develop in line with that. Thanks very much.
Yeah. Many thanks, Peter. Yeah, Paula, many thanks for bringing this note to the committee. Great to have awareness that this is coming, and I'm sure we'll see a demo when it's properly launched. Many thanks again.
Thank you.
I'll move on to item 12, the prescribing report. Michael, you want to say a few words by way of introduction?
Yeah, introduction from myself. Yeah, so I'm Michael Dennis, Head of Medicines Optimization for Norfolk and Waveney CCG. So this is the standard prescribing report based on December data as it is, and just looking through some key indicators, etc., and explaining some of the variations in costs and drug prices, which cause issues with rational budgeting. But anyway, so I'll move on. So section 2.4, explain category M, which is the medicines margin, which is the tool that the Department of Health, NHS England, use to remunerate community pharmacies for delivering the pharmacy contract. But they do that by changing drug prices on a quarterly basis, and you can see in section 2.5 the effects of them putting up drug prices to feed in money, overcooking it, and then taking money out. So in Q1, for instance, there was 10.4 million went in nationally. Q2, 48.9 came out. Q3, 26.8 million came out. Q4, 16.4 million came out. But what this practically means is that January, February, March, we should get a financial benefit in terms of the money coming back into category M, because it was previously, should we say, overcooked in terms of the amount of money put into drug pricing. So that's of benefit, but I suspect as we move into next year, there'll be an element of overcooking the repayment to CCGs. So I suspect we'll have a higher cut of category M to pay back early next year. But let's wait and see. Dependence forming medicines. I did suggest that when we got to January data, we might have got off third highest step in the country on anxiolytics and hypnotics. We haven't got to January data yet. We are very tantalizingly close to coming off of third and getting to fourth or fifth. So you can see some of the graphs. We are moving down faster than the national tendency to move down on that particular indicator. We have improved on opiates. We've improved in terms of percentile on gabapentinoids, although strangely we've stayed at the same position, 25th nationally on that one. Antibiotic prescribing, this is going to be in the prescribing quality scheme, as you'd expect, and we've been working with outlier practices, and we've seen some good improvements. There's still some significant outliers, which we are seeking to work with to understand and improve that situation. And I've just highlighted some of the top line indicators. I'm on the third draft actually at the moment of the prescribing quality scheme for next year. LMC are wanting us to aim to launch it in April, which I am planning to aim to launch in April. I've sent it round to the Clinical Executive Committee for comments on the clinical nature of the indicators and to the LMC on for their comments. And I'm hoping there'll be good agreement with that, and then we'll talk to finance about how much remuneration we wish to add to that work and what support we can provide as a team to get practices to deliver these. There is a move back to some cost saving areas because that is necessary, but there are also things that we should be doing anyway. So we're encouraging practices to work on, reducing opioids, high dose opioids, which is a high cost area, and changing the DOACs we're using, which practices are being encouraged to do through the impact and investment fund also, and some other things you would expect us to include. And so hopefully next month, April, I'll have agreed a financial envelope, and we can sign off the finances and aim to launch this at Prescribing Leads in the round starting mid-April. I am hopeful, but at the moment we've been working on various savings initiatives, shall we say. Comments welcomed.
Good, thanks, Michael. Any questions or comments for Michael? Maybe I can ask one around outlier practices. So what's your overall sense how that engagement is going? Are you getting the traction you hope?
The main work stream has kicked off in the West. We've got it on our agenda to tackle as part of our work stream from April to look at the top 2 or 3 within each other locality, but most of our outliers are in the West, has to be said. And our pharmacist Kemi has met with them and agreed some actions which we're looking at through the Prescribing Efficiencies Group, which meets every 2 weeks at the moment. And we're going through it with a fine-tooth comb. And if we're not achieving traction, then we'll escalate it through that group, I think is what we'll say. Yeah. But we are at least meeting, and they are agreeing some of the things we're asking them to do, certainly.
Thanks. John?
It's similar territory to Hein's question, really, Michael. In terms of the prescribing quality scheme for 22-23, obviously we've got a mixture of cost effectiveness, prescribing safety and prescribing quality, but are there more things that we could legitimately include around cost effectiveness? Because I'm just conscious about the financial challenge that we've got for next year, and in particular, I suppose Hein's comment about variation. We know there's some relatively very high cost practices in terms of cost pressure per U. Is there anything that we could legitimately build into the scheme around reducing that variation?
Well, we've got the prescribing quality scheme, which is for practices mostly to deliver themselves on things that they should work. You could argue, we should be working on anyway as a system. We've also got a work stream which includes other bits and pieces, shall we say, like the what we'll call the optimal alternative. The managing outliers is in there. There's things on diabetes, oxygen, dressings, stoma, for instance, discharge medicine services, which reduces hospital readmissions, and Optimize RX, for instance, and POD, high cost drugs. So there's other work streams that we'll tend to lead on, but we'll work with practices on, and they don't necessarily need to go in the PQS. I'm open to comments on that. I'm going to be sending in our list of savings initiatives hopefully tomorrow to James, and hopefully that is a good first cut. But some of it will be worked on primarily by practices with our support, and some will be primarily us leading on it as a team. So it's a mixture, I think. But if you want us to attempt to include more, they will expect the more remuneration, I suspect. Just a guess.
Yeah, I'm just conscious that the prescribing quality scheme, if everyone takes it up, would cost us £1 million plus, wouldn't it? So it's just making sure that when we come to agree it next time, we're clear on what on the scale of financial benefit we think we'll get for that, particularly in the light of the comment you made that a number of the things in here are things that probably we should be doing anyway, really.
Well, we should. It's just getting over that initial step of, I suppose, what's the benefit to us? I mean, the benefit to them is that they'll, achieve some good quality indicators and improve quality performance, but and reduce cost at the same time is what we're keen to promote. And yeah, it is a fine balance. I think we've certainly included a lot more of the savings initiatives and the bigger things that we should be working on anyway. If I'm repeating myself.
Okay, thank you.
Okay.
Yeah. Thanks, John. Andrew.
Yeah, Michael, I just wondered, have you got a view on the characteristics of those practices that are high antibiotic prescribers? I was thinking along the lines of continuity of care for patients. So whether there's any link with high locum use or in particular high turnover of prescribers in those practices.
That's a good question. I don't know off the top of my head. It's possibly worth exploring with the locality ADs to see if that is an explanation. In the practices that we managed to turn around, we found mostly that some old guidance rather than the current guidance was being followed, to be honest, and that there was just some refresher on what is current guidance, I think was the key learning from doing audit work in those practices, and being relatively supportive, but reiterating the fact that most patients who come in with an acute infection aren't necessarily antibiotic seekers, and GPs think they are. Research suggests more commonly antibiotic seekers when they're not actually antibiotic seekers, and just having that conversation and attempting to say no, I think is what we're suggesting.
And delayed prescribing.
Delayed prescribing, absolutely. There was supposed to have been an electronic solution for that, so on EPS, but that hasn't arrived as yet. So we just have to reiterate that, if they don't need a prescription now, then make arrangements or agreement on how they could access a prescription later if necessary. But okay, I will explore that with the ADs. That's something we hadn't necessarily thought of as we discussed it, but we found other things which I think were lower hanging fruit, to be honest, initially.
Thanks, Andrew. Sadie.
Yeah, one of my points was very similar to Andrew's, actually, in terms of correlating with, I mean, I was thinking of UTIs in care homes, for example. Yes. But not all, but many of the practices on that list are dispensing practices, and I genuinely don't know whether that has any bearing on the selection of antibiotics used, and where we're at with our formulary, and whether we have, I mean, presumably these drugs are not on the formulary because we have a target around certain antibiotic prescribing, but is there something we can do to look at that in respect of dispensing practices and the PQS?
Well, these drugs are on formulary, but the expectation nationally is that no more than 10% of all your antibiotics are these broad spectrum drugs. So they can be used, and it's just evidencing through audit and appropriate supportive challenge that they may or may not be using them for conditions which they shouldn't be using them for, and reiterating the national and local guidance, which is mostly published by NICE now. It is interesting that they are mostly dispensing practices. You could say there are some drivers to default to prescribe something more in terms of financial interest, but we would hope that isn't the case, but that certainly may be a factor in terms of thinking about prescribing or not prescribing. But these particular broad spectrum drugs, they can be used, but they're seeming to be used, I think, too often is what we would say in these areas. Sorry, somebody's just calling me. I'll just decline. Yes, I don't know how much further we can get in terms of, is there any suggestions in terms of what we should be asking in terms of drivers for dispensing practices beyond the obvious that I've just said.
Yeah, I've seen I think you've shared something before on correlation.
I have, yes.
Some patterns with dispensing behaviors. Maybe not to solve here in the committee. From my side, I very much sentiment-wise, I'm with John for the obvious reasons around can we use the prescribing quality scheme also to further the cause on a better cost outcome alongside all the other attributes, and maybe not so much to solve here in the meeting, but as you're putting the finishing touches on it and liaising with James, then maybe any idea that comes forward would be welcome.
Yep. So by the end of the week, I should have the latest draft, which I will hope to launch in April. I will see if there's other ones that will be. You need them to be relatively easy to do. Well, apart from the lot of work involved in doing it, and delivering high cost savings at the same time, and providing a level of remuneration which is acceptable to us and to those doing the work. So it's a fine balance. I will have a further look and see what else we can put in there. But as I say, we've got a work plan that sits alongside it, which predominantly we'll try to deliver.
Yeah. Good. Many thanks, Michael. We move on to item 13, the finance report. James is on the line, so over to you to give a brief summary and then open for any questions people may have, James.
Thank you. So as usual, I'll take the report as read, but highlight the key points and also clarify some of the points made in the report. So the executive summary, we can see as at month 10, the total year-to-date primary care and prescribing budgets are 0.1 adverse, actuals are 0.1 adverse to budget. The forecast adverse variance of the budget is 4.7 million. However, that does include 3.7 million of additional winter access funding and 0.9 million of additional ARRS funding to be received. With this factored in, the forecast is on plan at the moment. Moving on to the financial summary, this shows that GP prescribing is deteriorated by 0.8 million from month 9 to month 10. With the figures being 2 months in arrears, this is an undervaluation of the November estimate. In addition, efficiency savings have not materialised in the period, putting pressure on the forecast, with efficiency expectations already baked into our budgets. The prescribing efficiency forecast has been revised down in the month 11, so that will be reported next month to you, in order that the current achievement can be reflected. The £0.8 million movement has also included additional costs due to the delay of in-housing CSU meds management staff and an increase in dressings costs. The dressings movement is currently being investigated to understand the underlying reasons for this increase. Delegated primary care has increased considerably due to the additional ARRS costs of £0.9 million, but as stated, this comes with additional funding with it. Moving on to the detailed financial analysis, this shows the key drivers behind the prescribing overspend of 3.7 million against budget and some of the areas attempting to mitigate this. Then moving on to the specific funding areas, the System Development Fund. Again, this key area of investment is still showing predominantly on plan, but with a few small favourable variances to budget. Moving into delegated co-commissioning, the same favourable variances are showing here in terms of the Norwich APMS contract, the walk-in centre, favourable rent revaluations, offset by the existing pressure of QOF on the indicators past the CCG from NHS England at the beginning of this financial year. There is also a significant prior year accrual release within delegated, showing it in the position. There is also the £3.7 million of winter access funds, which are predicted to spend at the moment with no current budget. However, I again need to stress that there's a retrospective allocation due to be received from NHS England to offset this. Moving into GP and other prescribing, total variance of 3.7 million includes a prior release of 1.78 million, so the underlying variance is 5.48. This has been driven by growing diet pressures, COVID-related prescribing at the beginning of the year, lower than expected efficiency achievement, as said, that's been reevaluated in month 11, and additional pressures from both dressings and oxygen. That was all the areas I was going to highlight. If there's anything, any questions.
Thanks, James. Open for any questions, and I'll go first. Just to confirm, the current estimate for the total year is to be on balance.
Yes, correct.
Read on page 116, and you mentioned we get a retroactive funding for the overrun on the ARRS role.
Yes, we do.
So the sort of variance against budget, is that a cost feature, or are we simply able to hire more people than we thought we were, as the mix of both?
So we were given a budget for ARS at the beginning of the year, which when we breached that, which we now have, there's also a tranche 2 of money which is within our allocation. So we've just gone above the budgeted amount, and we can draw down that additional funding from NHS England, which is part of our overall allocation for those roles.
Okay, thanks. Any other questions for James? No, James, many thanks. Good to see. We expect to be forecasted within the funds allocated. So good to see. That takes me to any other business from anyone? No. Checking, Sarah, was there any question from the public during the meeting?
No, I didn't get anything. Thank you.
Yep. Good. For those who will take part in part 2, I suggest we start it at 3:30. There's a separate link for that. Leaves me just to thank you all for a good discussion today. I think we worked some topics really well, so many thanks for that, and also for the quality pre-read from the many people who've worked on that. Good to see you all. See you at the next meeting. Have a good rest of your day.
Bye, everyone.
Bye-bye.